So with that, I would like to introduce our keynote speaker, Erica Murray. Erica is the president and CEO for the California Association of Public Hospitals and Health Systems. Prior to this appointment, she was senior vice president and led the organization's policy and government relations efforts. Erica focuses on policies to challenge, support, and strengthen public healthcare systems' successful delivery system improvements. That was a tongue twister. She has a varied background in health policy spanning the federal legislative and executive branches, as well as the private sector. Erica will be interviewed by Bloomberg Law reporter Shira Stein. And Shira, I will turn it over to you.
Thank you, Susie. Thank you so much for joining me, Erica.
Happy to be here, Shira.
So today we're going to discuss different aspects of value-based care and some of the challenges that public hospitals in California are facing in trying to do this. At the end, we will be taking audience questions, so please submit those to the Slido app. How does bringing value into healthcare help patients, and how are California public hospitals doing that?
I appreciate the question. I'd like to start our conversation by introducing everyone to a patient who is receiving care at a public healthcare system in California. So this is Gina. Do we have that slide? Gina is 62. She is transgendered and identifies as female. Her partner recently passed away, leaving her quite devastated. She, of course, gave permission for me to share this story with all of you. She has stage 4 cancer, which has since metastasized to her legs. And she has been living in a home that was recently red tagged as having toxic mold. So you can appreciate that there is a whole variety of things that Gina's going through. In 2016, Ventura County, along with about a couple dozen cities and counties across California, started what we call a whole person care pilot, which is designed to redesign care. Instead of asking patients with a wide range of physical, behavioral health, mental health, and social needs to navigate an often complex system, we want to redesign that system around the patient. So Gina's whole person care team goes with her to her appointments, is helping her find alternative housing, is getting her access to mental health services for all of her specific issues, and is helping to improve her life overall. And although Gina is still in progress, I think the results of whole person care are a good demonstration of what high value care looks like in the safety net. If we can show the next slide, the outcomes of the Ventura whole person care pilot already, just since 2016, they've seen a 73% reduction in ER utilization, a 47% reduction in inpatient stays, and a 58% reduction in all-cause readmissions. So this is high value. It's recognizing the holistic needs of a very complex, socioeconomically challenged patient population.
So what are some of the challenges that California public hospitals are facing in this move to value-based care, and how have they overcome those?
Well, let me first explain who California's public healthcare systems are. There are 21 public healthcare systems in California. They're primarily county-owned and operated. They're also county-affiliated. CAPH, the California Association of Public Hospitals and Health Systems, also represents the 5 University of California medical centers. And these public healthcare systems are really the safety net of the safety net. At 21 systems, they represent just 6% of all hospitals in California, but they provide about 35% of all the hospital care for California's Medi-Cal beneficiaries and about 40% of all care for the remaining uninsured. And I would say that over the decades, the biggest obstacle or challenge to really embracing value-based care for public healthcare systems up to recently was really the sheer volume of uninsured. And we all know in this room that patients who are uninsured are often reluctant to seek care until they absolutely need it, which burdens a system in the emergency room. It's the most costly way to receive care. And so the passage of the Affordable Care Act and the expansion of Medi-Cal in California really was a game changer for public healthcare systems because it provided a foundation of coverage. It eliminated that, a lot of that reluctance, and it enabled public healthcare systems to flip their model from being reactive and waiting to see who they would get each day to a proactive model, leveraging their structures as systems. You notice I say public healthcare systems interchangeably with public hospital systems, and that's because they all have primary and specialty care clinics on their campus, but also out in the community that people wouldn't know were county-owned and operated or affiliated with UC. They just are primary care or specialty care clinics. So leveraging that structure as systems to receive more appropriate care in more appropriate settings.
Now that they have had that insurance, now that insurance has been more broadly used and more broadly expanded, what are the challenges that they're still facing in this move to value-based care?
Well, they have so many challenges. I would say there is an inherent challenge in public healthcare systems in that as local units of government and the University of California, they are looked to as a source of Medicaid or Medi-Cal funding. So they provide that non-federal share. But that in and of itself, we call that self-financing, that creates a structural financial limitation because at a 50% FMAP, our matching rate, the CMS or the feds will view 50 plus 50 as equaling 100. But if 50% of that is coming from your own pocket, from the counties or the UCs, that's really only 50 cents. So our challenge is always to seek how to adopt value-based structures that can also move us beyond that 50 cents limitation.
And there's a larger conversation right now happening in our country about the high cost of prescription drugs. It's a conversation happening in Washington, but it's also a conversation happening in local communities as people are unable to pay for their prescriptions and are avoiding getting their prescriptions. How are public hospitals affected by and getting involved in this larger conversation?
Well, I'm glad you asked. It is needless to say, public healthcare systems are really at the forefront of this issue as providers and purchasers of prescriptions for Medi-Cal and uninsured patients in particular. And the skyrocketing costs of prescription drugs, I think many in this room would agree, is just unsustainable. It's unsustainable for local governments, for state and federal governments, for taxpayers, for providers. I think one of the challenges that, in particular, that public healthcare systems are experiencing is that pharmaceutical companies have been attempting to distract Congress and Sacramento away from what we think is the fundamental issue of high drug pricing by focusing on a relatively small but super important for public healthcare systems program called 340B, which is a drug discount program whereby safety net providers receive manufacturer discounts on pharmaceuticals in order to stretch their resources and allow them to fulfill their safety net mission. And so we've had to spend a fair amount of time and energy from an advocacy perspective in fighting those efforts.
What do public hospitals need to be able to take on more financial risk for their patients? That's something that CMMI, the Center for Medicare and Medicaid Innovation, has been really heavily pushing. That's something that a lot of providers want to take on, but they're reluctant in some ways.
What do they need? I would say there are two things that are truly fundamental to the ability to assume more financial risk. And the first would be just stability. I mean, CAPH spent the better part of 2017, as did many people in this room, fighting efforts to repeal and replace the Affordable Care Act. And though that ultimately proved successful, and we're seeing a bit of a breathing room now, we know that any major cut to our funding sources, whether it be 340B or the declines in Medicaid DSH dollars that are set to go into effect in October, or a block granting of the Medicaid program that's called for in the president's budget proposal, something like that would truly undermine our value-based efforts to date and really pull the rug out from under safety net providers in California. And so we'll continue to fight those efforts from an advocacy perspective. The other thing I think that it's certainly not specific to public healthcare systems. It's true for all providers and plans and anybody in this industry is data. You cannot take on. You can take it on, but you can't succeed with financial risk unless you have accurate and reliable data that you're able to use through data analytics to achieve meaningful system transformation. And so without those two things, it's really hard to succeed under financial risk.
What do public hospitals see as the next steps in value-based care for them, and how can they get there? I know you guys have been working on different rounds of value-based initiatives, but what's next?
You know, it's actually related to my last answer. I would say that most public healthcare systems adopted an electronic health record and then quickly realized it didn't work for some reason. It was insufficient, or it was not interoperable, or there were just problems with that first round. And so most of them are either upgrading or scrapped the first round and are implementing a next generation. And those systems are what are enabling our members to really look to see who their patients are. Because you can't have sophisticated and successful discussions with plans or other entities if you don't know who your patients are, where they're getting care, whether it's within the system and the network or out of that network. And if you're just guessing, you can make some really poor choices about taking on too much out-of-network risk, for example.
How is the new interoperability rule, the proposed rule, going to affect public hospitals when you say you're already struggling with electronic health records?
I think interoperability is one of the fundamental policies that we need to see that in the safety net. And public healthcare systems certainly benefited from meaningful use and from being able to achieve meaningful use and move forward down that path. And we're seeing some promising signs with behavioral health providers. More needs to happen, and more investments need to be made in sort of the nitty-gritty software systems and interoperability within counties and across safety net providers. Because again, very often, low-income complex patient population, they don't care which emergency room they're going to, but we certainly those emergency rooms within a local community need to know how recently that patient was seen.
How do you account for having a more transient patient population when designing these value-based initiatives? Because that is part of the interoperability and electronic health record question.
It's so true. The patient population that many public healthcare systems see are very low income. And as we know, I'd actually say that having more than 13 million people in Medi-Cal in California, while successful from a policy perspective, is also a really searing indictment of the extent of poverty in California. And it's often observed, but I think it can't be overstated what a study in contrast California is in terms of having some of the wealthiest centers, like the place we're sitting in right now in downtown San Francisco, and to have such widespread poverty. And we know the social challenges that often come with poverty. And so many people, we're all familiar with the homelessness and housing crisis. And I think there are so many people who are on Medi-Cal who are just, who are perhaps not homeless, but are underhoused, sleeping in their cars, couch surfing, just struggling to make ends meet. And that does not lend itself to a healthy lifestyle. When you have very few choices in terms of where you're going to sleep or what access to what kinds of foods you have, it's very hard to ask a patient to maintain their HbA1c level. And so I think what it does is a call on all of us to embrace this concept of social determinants of health, really examine the connections between poverty and health, and build on this idea of whole person care so that we can meet patients where they are and get them the care that they need.
I know part of the social determinants of health conversation has been around how to properly pay for it. How are your hospitals dealing with that issue?
It's a great question. One of the things that we have been encouraged by with the current federal administration is an openness and willingness to acknowledge the social determinants of health and the possibilities of a program like Medicaid, perhaps investing in things like housing. And we are continually trying to sort of push the envelope in terms of what kinds of services Medicaid might pay for. And so we're encouraged to see successful and innovative pilots like in North Carolina, and we're trying to double down on those kinds of opportunities. We are also appreciative of Governor Newsom's embracing whole person care and including in his budget $100 million to invest in housing. Because again, you can't be healthy if you don't have a house, a home.
Another part of one of the president's other initiatives that they're getting ready to start rolling out is to lower HIV transmission rate. That's something that's still an issue in California. How are public hospitals working to do that?
It's a great question. I think we're a couple miles from Zuckerberg San Francisco General, which many people in this room know was at the epicenter of the AIDS epidemic in the 1980s, and unfortunately was the place where many people died. And now flash forward to today, where for lots of reasons and successful medications and care delivery, people are living with HIV/AIDS, and it can be treated as a chronic condition. I think it goes back to, for our patient population, particularly low-income people living with HIV/AIDS, I think of patients like Gina, where there are often a multitude of issues, not just an HIV/AIDS positive status, but lots of other issues. So again, what it requires is physical, behavioral health, social services coming together to make sure that if there's an opportunity to live with HIV/AIDS and be healthy, active, productive members of society, that we organize the care delivery system around that.
And speaking of chronic conditions, there are many that people are facing right now. How are public hospitals working to manage those chronic conditions better?
Great question. It goes back to what I was mentioning before. It's a bit wonky, but I think I'm in safe territory there with this crowd. Because public healthcare systems can provide the non-federal share for Medicaid, we have been front and center and really had a prominent seat at the table in California in designing and implementing value-based structures for more than a decade, particularly in the pay-for-performance space. That has been really designed around improving care for patients with chronic conditions. Again, leveraging the structure that we have as systems to keep people out of the emergency room, out of the hospital, and into primary and specialty care clinics. And so the incentives that we've built through these programs that are really multi-year, multi-billion-dollar incentive programs, they have been very successful in giving public healthcare systems initially needed investment in infrastructure and process improvements to sort of lay the groundwork for improved care for chronic conditions. And now we're seeing really the ability to move the needle on health outcomes. So for example, one of our pay-for-performance programs recently, I think it was between 2015 and 2018, as a result of this program, more than 3,600 additional people now have their HbA1c under control, which again, for the patient population we're serving, that's huge. And we all know in this room that if you can manage your HbA1c, you also have a reduced risk for cardiovascular conditions and stroke. So we're trying to move into the health outcome space.
And speaking of designing your own value-based initiatives, what sort of things do you take into account when you're thinking about designing new initiatives?
Oh, well, having had more than a decade of experience with this, we have built up a fair amount of lessons learned. I would say one would be to always, in terms of target setting for performance-based targets, to always set those targets to be as ambitious as possible, because systems will do what they are paid to do. And if you really set the bar high, they will meet those, they will do what they can to meet those standards. At the same time, you have to set those targets such that it's not impossible. So whenever we're designing these programs, we want to try to be as ambitious as possible without setting our members up to fail. And that can be an unknown on the front end. I would also say that early on, we recognized that each of our systems was in a very different place in terms of quality improvement and sophistication. And so we allowed them to design their own value-based and performance-based structures themselves to move along individualized continuum. And that proved to be of assistance to them, but it didn't enable a comparison of apples to apples. And at the end of the pilot, we weren't able to, in a really determinative way, say which approach and strategy was successful because they were too individualized. And we've since learned that it is important, even if it's a struggle for some, to be as standardized as possible. And then I would say the last lesson learned that comes to mind is, of course, to ground the design of any value-based or performance-based structure in evidence. It's really important that measures and structures be evidence-based. And as we're in this nascent period of recognizing social determinants of health and the importance of care transitions and sort of systemness, if there isn't a measure out there that's been fully vetted, perhaps it's time to test one out. And there needs to be sufficient flexibility and openness in whatever policy is being designed to encourage that innovation.
Great. Well, thank you so much, Erica. I'll turn it over to Susie.
Thank you.
Thank you very much. Thank you very much. We don't have any audience questions for this, so thanks to both of you. And yeah, we'll get ready for the next panel.
Thanks.
And as a reminder, you can ask questions via slido.com. So please feel free to go there. And the code is M380. And we will be taking questions after each panel. So ask away.